So we continue. Benign connective tissue tumors as an aneurysmal bone cyst. It is also known as a pseudocyst or a solitary lesion of bone. Why pseudocyst? Because it is not having epithelial lining. So not classified as a neoplasm since it retraces after the incomplete tumor. Etiology is unknown. Several areas arise after trauma or fraction, may arise de novo in bone without a definite pre-existing lesion. Rarely malignant tumors of bone may contain benign areas similar to aneurysmal process or ABC. Clinical features under 20 years, no genital erection, history of trauma, pre or post development of the lesion, seen in every part of skeleton, rarely skull and bones of the hands and feet. Tender or painful, particularly upon motion, affected bone movement limited, swelling over the area of bone involvement, gross finding at the time of surgery, excessive bleeding upon opening the bone region, tissue resembles a blood soaked sponge, large pores representing cavernous spaces of lesion. Some studies show annular bone cysts with elevated vascular pressure as high as arteriovenous levels. Four phases of pathogenesis: osteolytic initial phase, active growth phase, rapid destruction of bone, and subperiosteal blowout pattern. Mature stage or stage of stabilization, formation of distinct peripheral bony shell and internal bony safety and rapidly produce soap bubble appearance. Healing phase showing progressive calcification and ossification, dense bony masses. All manifestation: radiological features: expansion of bone, cyst with a soap bubble appearance, cortical bone may be destroyed, periosteal reaction may be present. So soap bubble appearance on radiograph. Histopathologically, fibrous connective tissue stoma is seen. Many cavernous or synovial blood-filled spaces are present. Blood-filled spaces may show thrombosis, numerous young fibroblasts, many multinucleated giant cells in a patchy distribution, varying amounts of hemosiderin pigments, and new osteoid and bone formation. So this is the picture of aneurysmal bone cyst with blood-filled spaces and fibroblasts and numerous giant cells. So next entity is the lipoma. So benign neoplasm of adipose tissue composed of mature fat cells. Age predilection for adults, no gender predilection. Buccal mucosa and buccal vestibule, tongue, floor of mouth and gingiva. Sessile or pedunculated growth, soft, smooth surface modular condition. Typically asymptomatic, less than 3 cm, occasionally larger, more superficial lipomas look yellowish in color because of the fat cell color. So typical picture of lipoma will show you localized swelling less than 3 cm and its color, it may be a pedunculated or sessile one, and its color is yellowish. The slow growing benign neoplasm, developmental or reactive one, then sessile or pedunculated painless, diffuse or superficial, yellowish surface discoloration and movable beneath the mucosa. So multiple head and neck lipomas are seen with neurofibromatosis, Gardner syndrome, encephalocraniocutaneous lipoma, multiple familial lipomatosis, and Proteus syndrome. Histopathological features: gross pathology will show yellow colored fluid in aqueous solutions, usually well circumscribed, may show a thin capsule, mature fat cells, lobules of fat cells separated by fibrous septum. So histopathologically, it is composed of mature adipocytes admixed with collagenous tissue and surrounded by fibrous capsule. So you can see in histopathology of lipomas, there is the Septi divided by connective tissue stroma, and that septi will contain the cells, that is adipocytes or fat cells. So our departmental chart diagram will show lipoma like this. Next is the varicosantoma. It is an uncommon lesion of uncertain nature, reactive process, etiopathogenesis, damage of the squamous cells, increased turnover of epithelial cells, deposition of epithelial debris. Debris are engulfed by macrophages. Clinical features: solitary lesion with papillary growth, sessile or pedunculated with a rough surface, involves alveolar ridge or chinchilla, mostly seen in middle-aged persons, associated with the other lesions. Histopathologically, variable degree of parakeratosis, extremely long, elongated reticulus, large foamy cells in connective tissue papilla, inflammatory infiltrate. Foam cells are suggested as lipid-laden macrophages, Langhans cells, and the fibroblast. Next one is the myxoma, which is a soft tissue myxoma. It is an abundant myxoid ground substance, mucopolypolysaccharide, mainly hyaluronic acid. True neoplasm made of tissue resembling primitive mesenchyme. Benign lesion does not metastasize, frequently infiltrates adjacent tissues. Intraoral soft tissue myxomas extremely rare. All the cases occurring in jaw bones commonly are original myxomas. Histopathological features: loose textured tissue with delicate reticulin fibers, mucoid material probably hyaluronic acid, varying number of stellate cells and occasional spindle cells interspersed throughout. No encapsulation, may embed into surrounding tissue. So loose textured tissue with delicate reticulin fibers. Next, we will move towards the next classification of benign connective tissue, that is the vascular or blood forming cells to benign tissue connective tissue tumor. In that oral vasoformative tumors, there are of two types, hemangiomas and vascular malformation. Hemangiomas manifest within first month after the birth, rapid proliferative phase and slowly involve. Vascular malformation present at birth, grows with the child and fails to regress. Head and neck lesions are the commonest site for these lesions. So, differentiation between hemangiomas and vascular malformations. Hemangiomas are a rapid endothelial cell proliferation in early infancy, whereas the vascular malformation normal endothelial cell cycle growth cycle. Not present at birth, whereas vascular malformation present at birth arise within the first month of life, hemangiomas, whereas vascular malformation affect veins, capillaries, and lymphatics. Hemangiomas rapid proliferative phase, vascular malformation, anomalous development of vascular plexus, more stable, fail to regress, slowly involved to non-existent. This is the classification of vasoformative tumors. Vasoformative tumors as hemangiomas and vascular malformations. Hemangiomas are divided into capillary hemangiomas, cavernous hemangiomas, and mixed hemangiomas, whereas vascular malformation are divided in or classified into venous malformation, intravascular venous malformation, capillary malformations, arteriovenous malformations, lymphatic malformations. Pathophysiology: they originate from placental cells, involves three stages: undifferentiated capillary network, capillary hemangioma; retiform developmental stage malformation, venous artery or capillary malformation; final developmental stage, that is the venous malformation and lymphangioma; and proliferative hemangioma expresses is estradiol 17 beta receptors. So they are having three stages: undifferentiated capillary one, retiform developmental stage, and final developmental stage. So hemangiomas are associated with the following syndromes. Very important one, can be asked as a 2 mark SAT question. So renovarscular Weber syndrome, also known as autosomal dominant inheritance, multiple telangiectasis, occasional GI tract involvement, and occasional CNS involvement. Sturge-Weber Dimetri syndrome, familial. Sturge-Weber Dimetri syndrome. It is a non-inherited and non-familial port-pine stain, leptomeningeal angioma. Cassavage-Merit syndrome, thrombocytopenic purpura associated with hemangioma, consumptive coagulopathy, microangiopathic hemolysis, intralesional fibrinolysis, Mac- Maffucci syndrome, hemangiomas of the mucous membrane, and dyschondroplasia. Von Hippel-Lindau syndrome, genetic transmission variable hemangiomas of the cerebellum or the retina, cyst of the viscera, Klippel-Rinoni-Weber syndrome, Port-Weinstein, and angiomatosis of the extremities. Oral hemangiomas common in head and neck region, uncommon in oral cavity. Clinical features: age, early age. Females are more commonly affected than the males. Lip, tongue, buccal mucosa, and the palate. Flat or raised lesions of mucosa, deep blue or bluish red. Seldom well circumscribed, readily compressible, feel slowly when released. Central hemangiomas in maxilla or mandible, bone destructive lesions, and will show the honeycomb appearance on radiograph. Clinical features of the hemangiomas are seen in infants and children, bluish red in color, raised and circumscribed nodular one, frequently traumatized or ulcerated one. Peak incidence of central lesions in the second decade of life. Female predilection is more. Lip lesions are known as the microcherry lesions. Hemangiomas are also known as the pigmented lesions because they show variations in colors. Another picture of hemangioma. Radiographic features: angiography is most useful. Ultrasonography contrast enhance MRI. Intraosseous lesions appear honeycomb pattern, and CT scan shows expansile process. Histopathologically, it is divided into two types: capillary hemangiomas and the cavernous one. When these hemangiomas or these lesions composed of many small capillaries lined by a single layer of endothelial cells and connective tissue stroma of varying density, then it is called as the capillary hemangioma. Whereas the cavernous hemangioma will show the large dilated vessels, endothelial cell hypoplasia, and large number of mast cells. So large dilated blood sinuses with thin walls. This is the histopathological picture of the cavernous hemangioma. Next important entity is the nasopharyngeal angiofibroma. Etiologic hormonal theory: nasopharyngeal periosteum originates in upper part of phenopalatine foramen. Smoking as a positive correlation. Destabilization of adenomatoid polyposis coli, APCG, proto-oncogenes. So occurs exclusively in males. Nasal obstruction, epistaxis, trismus, facial swelling, proptosis, depression of palate, and facial deformity are the clinical features of this disease. Histopathologically, it will show encapsulated tumor, pronounced vascular network, thin walled blood vessels, haphazardly arranged connective tissue, plump fibroblast mast cells in the stroma. Next is the lymphangioma, benign hamartomatus, hyperplasia of lymphatic vessels, developmental malformation of vessels that have poor communication with lymphatic system. Classification: simple hemangiomas, cavernous hemangiomas, and cystic lymphangiomas or cystic hygromas. So they are present at birth or before the age of 10 years. Both sex equally affected in this condition. Very common in head and neck region. Tongue, palate, buccal mucosa, gingiva, and the lips are the commonest silent oral manifestations. Superficial lesions show capillary lesion of normal mucosal color. Deeper lesions will show diffuse nodules or masses. If in tongue, they are called as a macroglossia. Small lymphangiomas on alveolar ridge of neonates regresses spontaneously. Picture of lymphangioma in newborn baby. Histopathologically non-encapsulated when numerous dilated lymph vessels, single layer of endothelial cells intercrossed between adipocytes and muscles replace the connective tissue papillae, loose fibrovascular stroma. So histopathological picture of the lymphangiomas, schematic presentation. Next entity is a leiomyoma. It is again a benign tumor of smooth muscle region, origin from vascular smooth muscle. Three types: solid leiomyomas, vascular leiomyomas, and epithelioid leiomyomas. Clinical and radiographic features occur at any age, usually slow-growing, firm nodule. Asymptomatic solid leiomyomas are typically normal in color, although angiomyomas are bluish hue. Most common sites are lips, tongue, palate, and cheek, extremely rare in Proteus. Histopathological features: solid leiomyomas, interlacing bundles of spindle-shaped smooth muscle cells. Angiomyomas, multiple tortuous blood vessels with thickened walls caused by hypoplasia of their smooth muscle coats. Intervening bundles of smooth muscle may be found between vessels. Epithelioid leiomyomas, primarily epithelioid cells rather than the spindle cells, and treatment is the local surgical excision. Rhabdomyoma, benign neoplasm of skeletal muscle, striking predilection for the head and neck. These can be classified into two major categories: adult and fetal rhabdomyomas. Fetal rhabdomyomas, less mature appearance and consist of a haphazard arrangement of spindle-shaped muscle cells that with sometimes are found within a myxoid stroma. Considerable cellularity and mild pleomorphism. Clinical features: adult rhabdomyomas will show 70% in male, pharynx, oral cavity and the larynx, floor of mouth, soft palate and base of tongue. Nodule or mass can grow up to many centimeters, some are multicentric. Fetal rhabdomyomas, similar male predilection, most common location, base and periauricular region. Histopathological features composed of well-circumscribed lobules of large polygonal cells which exhibit abundant granular eosinophilic cytoplasm, often demonstrate peripheral vacuolization that results in a spider web appearance of cytoplasm, focal cells with cross striations. Histopathologically composed of large round cells, granular eosinophilic vacuolated cytoplasm, irregular cross striations, pleomorphic polygonal muscle cells, cellular or myxoid stroma. Chondroma, it is a benign tumor composed of mature cartilage. Clinical features: age, third to fourth decade of life, no gender predilection, lesion painless, slowly progressive, swelling of jaws may cause loosening of teeth. Right anterior part of maxilla, particularly the midline, mandible posterior to the canine, and nasal septum. Radiographic features: destructive lesion, irregular reducent or motile appearance, root resorption of adjacent teeth. Histopathological features: circumscribed mass of mature hyaline cartilage, well formed lacunae containing the small chondrocytes with pale cytoplasm and small strong nuclei. Many show areas of calcification and necrosis. Osteoma, commonly asked SAQ question. Benign tumor composed of mature compact or cancellous bone in an endosteal or periosteal location. Clinical features: not common in oral cavity, age common in young adults, periosteal in origin, circumscribed swellings on the jaws and asymmetry of face. If endosteal in origin, slower to present manifestations, pain not common, multiple osteomas of the jaws and skull in Gardner syndrome, rarely soft tissue osteomas in tongue. Radiographic features: well circumscribed radiopaque mass. Histopathologic features: well circumscribed lesion, either composed of extremely dense compact bone with minimal marrow tissue, compact osteoma, or post-cancellous bony trabecular and fibrofatty marrow, cancellous osteoma, sometimes foci of cartilage present, osteochondroma. Osteoid osteoma, benign tumor of the bone, Nature of the lesion unknown. True neoplasm of osteoblastic deviation or lesion as a result of trauma or inflammation. Clinical features: age, young persons, side femur, tibia, rarely in the jaws, severe pain, sharp, worse at night, relieved by aspirin, localized swelling of soft tissue over involved area. Radiographic features: lesion rarely large than 1 centimeter, small, round or oval, radiolucence is surrounded by sclerotic border. Histopathological features: central lesions composed of complex osteoid tissue, interspersed by vascular connective tissue, formation of definite trabeculae outlined by active osteoclast and foci of bone resorption, compact osteoid tissue. Histopathological picture: osteoid osteoma, nature is debatable. True neoplasm or osteoblastic deviation, result of trauma or inflammation, occurs in young females more commonly. Severe pain and soft tissue swelling, common in tibia and the femur. Radiographic features: ovoid radiolucency surrounded by sclerotic bone, may contain some radiopacities. Histopathological picture: compact osteoid borders by osteoblast. Osteoblast contain atypical mitochondria, vascular connective tissue, many axons throughout the regions. Granular cell myoblastoma, controversial regarding the nature and the origin. Nature: neoplasm, developmental anomaly, and the trauma-induced. Origin is from skeletal muscle, neural tissue, histiocyte, fibroblast, or pericytes. Most commonly seen in oral cavity, dorsal of tongue, soft palate, sessile, painless, firm nodule, pale or yellowish in color, female predilection. Histopathologically, it will show ribbons of granular cells separated by fibrous septum. Appears to be streaming of large polygonal cells, coarsely granular, eosinophilic cytoplasm, eccentric located nucleus. Torus palatinus. We are having cast in our department of same. So it will cover 5 marks in practical exam and 2 marks in theory, 3 marks in short note on theory exam. A common exostosis occurring in midline of the wall of hard palate, bony trap protuberance, pathogenesis unclear, hereditary condition, local environmental factor, masticated stress, and multifactorial one. Clinical features: females affect more than the male, 2 as to 1. Age may occur at any age. Racial predilection: American, Indian, and outgrowth in the middle line of the palate, important one. That's why the name given, Taurus palatinus. Classified clinically according to the shape as flat, spindle shape, nodular, and the lobular one. Overlying mucosa may be normal, blanched, or ulcerated. So this is the classical picture of Taurus palatinus. Histopathological features: dense compact bone or shell of compact bone with a center of cancellous bone. Taurus mandibularis. Taurus mandibularis is an exostosis found on lingual aspect of mandible. Etiology is unknown. Hereditary condition, local environmental factor, masticated states, and multifactorial one. Clinical features: variable size and shape, lingual surface of mandible above the mylohyoid bridge, usually bilateral, may be unilateral, single or multiple lobes. So lingually, it is present in a multiple lobes or a single lobe. Histopathological picture: dense compact bone or shell of compact bone with a center of cancellous bone. Next is the multiple exostosis, less common, unknown etiology on buccal surface of maxilla below mucobuccal